Good evening, everyone. I'm presenting a paper on surgical outcomes in acute acquired comitant esotropia. This is a multicentric study studied in 3 different centers. Acute acquired comitant esotropia, or ACE, is a relatively rare condition. It has a sudden onset of comitant esotropia with diplopia. The exact cause is unclear in most cases. There has been a recent rise in the cases of ACE after COVID-19, especially due to excessive near work like prolonged gadget use. For ACE, different treatment options have been suggested, like botulinum toxin or surgical intervention, for good prognosis of binocular function. My objective is to assess the motor and sensory outcomes of surgical correction in ACE. So this is a multicentric study. It's a retrospective observational study conducted over 18 months, and my sample size is 22. Inclusion criteria includes all cases which is diagnosed and operated for ACE with or without diplopia from Jan 2023 to June 2024. Exclusion criteria includes if for all cases MRI brain was done, and if there was a neurological lesion, those cases were excluded. Any systemic diseases like myasthenia graves, these were excluded. Past history of strabismus or strabismus surgery, or if there's an accommodative component present, we have excluded those cases. Methodology: records of patients diagnosed with ACE who have undergone surgery in that time period at 3 different centers were reviewed, and we have studied all these factors, which I'll be explaining. So what we found was the age when squint was first noticed was as less as 3 years of age to 31 years. So both children and adults have presented with acute sudden onset of esotropia plus or minus diplopia. And age at presentation was 4 to 33 years with a mean of around 8 years of age. First consultation was after how long of onset? It was as early as the very same day of onset of esotropia to as late as 30 months. None of them had any history of strabismus trauma or any patching history. All of these cases had normal external ocular examination, anterior posterior segments, full extraocular movements, normal MRI brain. 45% were emmetropic, remaining had either minimal myopia or astigmatism, and all had a best corrected visual acuity of 6/6. Precipitating factors, we found that many of them, most of them did not have any precipitating factors, but many of them gave history of increased screen time of above 5 hours per day. Some of them gave history of fever, some gave history of irregular glasses use. At the time of surgery, age was around 4 to 33 years. After how long of onset was surgery done? Surgery was done, basically surgery was planned as soon as stable measurements, consecutive stable measurements were available for the patients. The type of surgery in 2 centers, a pure recession resection in one eye was performed. In one center, bimedial recession with or without lateral rectus resection was done. No intraoperative or postoperative complications were there. No reoperations were there. Now coming to the postoperative results. Postoperative, we have seen results for up to 6 months. All out of 22 patients, 20 patients were orthophoric, and on cover test, we can see that out of 22, 19 patients had just esophoria at 6 months. So this suggests excellent motor outcome. On measurement of squint, preoperatively was about 40 to 50 prism diopters, and postoperatively that was reduced to 5 to 10 prism diopters. So this is suggesting a very good motor outcome. Coming to the sensory outcomes, preoperatively, out of 22 patients, 10 of them had suppression and 12 of them had diplopia. Nobody had fusion. Post-operatively, you can see that nobody had diplopia. 11 of them had fusion and 11 had suppression. And pre-operatively, the 10 out of the 10 people who had suppression, 4 had developed fusion, and out of the 12 who had diplopia, 7 had developed fusion. And coming to stereopsis, 13 had no stereopsis pre-operatively, whereas post-operatively 13 recovered very good stereopsis. So we are saying we got very good sensory outcomes. So the conclusion is that it's a comparatively rare type of squint with limited large-scale studies. There's a recent surge in ACE that has been noted in all the centers. Surgical correction is not only a permanent management modality for ACE, but also it provides very good motor as well as sensory outcomes. Sensory outcomes were as good as the motor outcomes, and the post-operative stereopsis is expected to recover favorably and may take longer. Thank you.
AAC is not relatively rare. Nowadays it has become fairly common.
Yes, sir.
Don't say relatively rare.
Okay. Yes, sir.
So particularly after COVID, I am seeing a lot of cases of not only AAC but other types of squints also.
Yes, sir.
We don't know. See, the primary problem in any squint is not the muscle. The primary problem is in the brain. That we have to remember.
Yes, sir.
What we are trying to do is operating, as somebody said, the operating on the bones for the neurological problem is what we are doing. Orthopedic solution for neurological problem. Okay, good, well done.